I'm delighted to have a chance to talk to you today. The title of this talk is, Will Pill Control Fix Our Problem? The Allure of Simple Solutions to the Opioid Crisis. I'm a physician at the University of Alabama at Birmingham School of Medicine. My disclosures are shown. I don't receive any pharmaceutical money. I have some stock holdings, which I show in the slide. Case examples here are disguised and represent my own and those from expert colleagues. The opinions here are my own and do not represent those of my employers. 3 basic points. The CDC guideline was a serious response to a serious problem, but it is mostly not being followed and not being respected in emerging practices. And the question is, how did we get here and how do we get out? I want to focus this comment specifically on the 7th recommendation of the CDC guideline. It concerns people who are already receiving opioids for chronic pain. And it says for patients on opioids already, evaluate the benefits and the harms. And if the benefits do not exceed the harms, then work with the patient to reduce the dose, or do so if the patient requests it. Note that word harm. It's something that is seen and observed in the care of the patient. It's not a statistical risk. There is no proposed dose target that patients have to be brought to under that recommendation. But in fact, where practice has gone is quite a bit different than what that guideline would seem to suggest. This is a story that I reported in Hill.com. It's like many that I've seen, cared for, and heard about from colleagues. The patient was an older woman who had been on opioids for painful arthritis. She had her doses increased slowly over many years, and they were stable at over 200 milligram morphine equivalents. She had a range of daily activities, and 3 physicians unilaterally reduced the dose of her opioids 90% in 3 single chops over 18 months. She became miserable, dysphoric, she retreated to her bed, and she would stop taking most of her medications because she felt so bad. Unfortunately, that means she stopped taking the medicines designed to prevent rejection of her transplanted kidney. As a result, that kidney was rejected, as confirmed on biopsy, and she is headed for dialysis. This is just one of many cases I hear about. Key questions I want you to think about. Was this patient better off as a result of this care plan undertaken on behalf of her safety? Should patient consent matter in cases like this? This wasn't with her consent. And for physicians people who engage in health policy, ask this: do we normally carry out involuntary procedures on otherwise stable patients on the premise that we will protect them, even when there are no prospective data to show that those practices work? I would say no. Another case I want to share with you. This is actually from the comment section of an article I published with Dr. Adam Gordon on Stat News this past February. Painful Pat writes, I was once able to handle the pain by various means, but the major tool in my healthcare box was the opiates that made my life somewhat close to tolerable, but what now? I'm currently dying of pain for something I had nothing to do with. Death now seems like my only option. Mima will miss her grandbabies as well as my children, but this ugly world has given me no options. Those are public comments. In the 2 articles I published online, the comment sections are filled with dozens of commentaries reflecting suicidal ideation. Needless to say, in response to this, 2 of us actually intervened and tried to urge Painful Pat not to kill herself. I gave this talk, or a version of it, a few weeks ago, and was actually told that in the end, Painful Pat did kill herself, which suggests we have a serious problem. I actually received notices about suicides and suicidal ideation almost every week. So how did we get to this? This is a sign from an actual patient took out of doctor's practice. Beginning February 2017, morphine equivalency dosing will decrease until CDC guidelines are met. Target is 90 milligrams of morphine. If you've listened to the first part of this talk, you already know this violates recommendation number 7 of the CDC guideline. But somehow we wound up here. And I think a number of things came together to cause a practice shift that far outstripped the words of the CDC guideline. One aspect was powerful rhetoric from leaders that made the news. The day the guideline was released, we had these words: almost all the opioids on the market are just as addictive as heroin. What's the message that sends to doctors? The day you write that prescription, doctor, you are basically a heroin dealer. It's a very powerful pressure. For the majority of patients, the risks of opioids will outweigh the benefits for chronic pain. For the vast majority of patients, that's an untested statement, but one that sounds like fact when presented by a public leader. And it changes how the guideline itself is read. We also have a rhetoric that implies this is a very simple problem. As Vermont's Governor Pete Shumlin said, we didn't have this problem until opioids were being handed out like candy. Candy rhetoric is so interesting because it trivializes both the prescription, the patient who receives it, and the decision to write it. And he says, continuing, we could fix the majority of this problem with a click of our fingers. Whose fingers are going to fix this? Whose fingers will click? Doctors. There are also many regulatory and programmatic initiatives that are designed to push this change in care that is not recommended by the guideline, but one example is a regulation from the state of Maine. There they say, no patient can receive over 100 morphine milligram equivalents. The law has a remarkable exception. If a physician can show that they have personally caused severe harm to their own patient by reducing the dose, they can petition the state for permission to stop causing harm to their patient. This, to my knowledge, is the very first state regulation requiring physicians to violate their Hippocratic oath in order to seek permission to stop violating it. 11 states currently legislate doses, and the VA Department of Defense guideline algorithm actually also recommends these involuntary dose reductions. Underlying these regulatory and rhetorical forces are some misconceptions, and I want to share 3 of them with you. One is an oversimplified notion of addiction. This headline from the Washington Post tells the story. 1/3 of long-term users say they're hooked on opioids. And hooked is a word that does a lot of duty here because it implies a very simple understanding of opioids. You see, if a pill comes along and hooks you, and that makes addiction, it sounds an awful lot like a parasite comes along and infects you, and that makes malaria. And once you have that understanding, solving the problem is as simple as getting rid of the virus or the pill or whatever it is. But that really does some injustice to what we know about addiction. A remarkable report was issued by the Surgeon General last year, Facing Addiction in America. And it gives us an overall picture of all the forces that come together to essentially help us understand the difference between people who don't develop addictions and people who do. They include genetics, early family life, risk-taking, and other personality characteristics. Substance access. By the way, in case you don't understand, we doctors do have responsibility for that aspect of the equation, and we have played an adverse role. Life opportunities. The work by Deaton and Case has shown how powerful effects of not having opportunities in your own community spurs opioid seeking and corrective help. All of these factors influence whether addiction actually develops. And what we've done is adopt a blinkered understanding that sort of cones down the problem of addiction to access to a prescription. It creates an easy target for regulators and legislators, but it neglects most of the problem. Prescription opioids are actually on a slow, not large, but modest 5-year downward slide, while prescription overdoses increase. These are statistics from my own community, Jefferson County, Alabama. You see a rise in the total number of overdoses, and I've added extra color here to show that fentanyl now has more than doubled in terms of its contribution to overdoses. Those that are potentially attributable to prescribed opioids have dropped like a rock. Clearly, this problem is more complicated than the blinkered view would suggest. Another misunderstanding that has played such a powerful role in this change in practice is the suspension of the ordinary rules we use for evidence-based decision-making in medicine. And those are rules that have helped us in the past, and we should not abandon them now. Imagine 2 stable patients, each of which has a concerning number. One is my patient with a cholesterol of 270 who's working and functional. And the decision is, should I push that patient to take a statin drug? The other is a patient with chronic pain who's on 120 milligram morphine equivalents. Maybe I inherited that patient from someone else. And the question is, she's working and functional, but do I need to push her to have her dose reduced? How do we make those decisions? In the case of cholesterol, the way we do it is we look at the overall absolute risk of harm to the patient from heart disease, in which that cholesterol number plays a small role. A calculator like this one from Mayo Clinic, takes into account age, gender, smoking, diabetes, blood pressure, etc., all the factors. And then you say, given this absolute risk, can I modify it by adding a statin drug? How are we making that decision with respect to the morphine milligram equivalent dose? Basically, a lot of practices, a lot of programs, and a lot of legislators have adopted this policy that just make the number go down. It's going to be better. And it's not that we don't have the data to do the statistical models. They are published, they are available in online calculator tools, We have every opportunity to use the same approach to the opioid dosing issue as we do require for cholesterol. We're just simply choosing not to use the data, and that should concern you. And that really reflects the third concept, which is the allure of simple solutions. Don't neglect the need for evidence. Involuntary tapers and discontinuations of opioids in patients who are stable are based on an observational correlation of dose with risk. It assumes that reducing the dose in each patient will reduce their personal risk. None of this data is from randomized trials. There has been some real treachery from observational data being allowed to guide practice in the past, and I think many of you know that. When I was a resident back in the 1990s, I gave my senior talk on how and why estrogens are so powerfully protective for the hearts of women who have passed menopause. The question wasn't, do they help? The question was, why are they so beneficial to women? Because there was abundant observational correlational data showing that women on post-menopausal estrogens have lower rates of heart attacks. And we proceeded to put lots of women on those estrogens, except finally when a trial was done, it turned out that we had the entire understanding wrong, that those estrogens were causing heart attacks. And there was other characteristics of people who took estrogens postmenopausally that were actually protective. So choosing to embrace observational data to guide your practice is often very, very dangerous. I would suggest here that we re-understand the notion of risk associated with opioid dose. Dose-risk correlations are not the same as dose-response curve. Dose of opioid, as prescribed in a doctor's office, is correlated with mental and social vulnerabilities. You may think it's wrong, and it probably is often mistaken, but physicians historically elevated doses on patients who had psychological problems, who presented with a lot of emotional distress. And these factors multiply the risk to an individual by factors of 2 to 20. So who has the higher overall risk of overdose or suicide in VA data? Is it the man with PTSD on 10 milligram morphine equivalents? Or is it the man on greater than 200 milligram morphine equivalents, but no mental illness at all, and certainly no PTSD? It's the first guy, the 1 on 10. So why would you hinge all of your opioid policy on a number alone? What we need is care, not pill control. We need mental health care in particular for people with chronic pain, pain education, and often monitored continuation of the opioids. Professionals across the country are deeply concerned about this. I helped get the signatures for 2 different petitions this past spring, one to the Centers for Medicare and Medicaid Services, another to the National Committee for Quality Assurance. These were both in response to standards that would force doctors to reduce doses or risk looking bad or risk having payers refuse payment for doses that were high, even if the patients were currently stable. Over 80 people signed the letter to the National Committee for Quality Assurance. They included 84 who assisted the CDC guideline. They included 5 who edit scholarly journals in the addictions. I won't go through the rest of all the credentials, but suffice it to say, these are mostly people who are deeply concerned about addiction and pain as a professional commitment in the academic realm, and they are deeply worried about the pendulum swing and the effects it's having on patients. What should we do? I suggest we start by taking the extremely good advice that was provided to the CDC by its own opioid guideline work group. What they suggested last year, prior to the release of the guideline, was that the CDC engage in support for integrated care of patients with pain, and that there be monitoring of the guideline for implementation for evidence of impact and unintended consequences. And those are very good suggestions that I think we need to do a lot more of. My suggestions to the CDC, and candidly I sent these to the CDC folks prior to this talk so that they would know about them, and they were very appreciative. They need to firmly clarify the content of Recommendation 7 in a highly public way so that people understand what it truly says, which is not just to chase a number. They need to report on the actual harms to patients of ignoring the content of that recommendation. They need to assemble the stakeholders to engage in a comprehensive outcome assessment plan from the guideline, and that has to be a diverse group. And they should task the Epidemiologic Intelligence Service, which looks at outbreaks, to investigate the massive outbreak, at least anecdotally, of suicides and public suicidal ideation, which is eminent on public media. They can use techniques of social listening like the FDA uses to look for adverse drug effects. This is something that they need to get on right now. Regulators and payers need to embrace care and risk mitigation. They need to stop number chasing, the morphine milligram equivalents. Bear in mind, chasing a number the pain score, is part of how we got into this mess. So I don't believe that chasing a single number, the morphine milligram equivalence, is going to be how we get out of it. With that, I want to thank you for your attention. I've put up a Twitter handle, an email, and also some references in case you're interested. Thank you very much.